All right. Hi, everyone. Thank you for joining us today. So we are NANS, which stands for the North American Neuromodulation Society, and we are the Resident Fellow Section Young Neuromodulators Committee. Sylvie, next slide, please. So we're excited to announce our very first National Medical Student Journal Club, where we have 4 medical student presenters who will talk about a couple key landmark articles on spinal cord stimulation.
Welcome, everyone. I'm Ankur Patel. So before we get started, we just want to go over some ground rules. We encourage questions, so please use the question panel to go and type your question. All questions will be answered at the end of the webinar if we're not able to get through to it during the program. Please try to keep yourself mute during the webinar. And if someone's not able to make it, the webinar will be recorded and available on the YouTube channel within about 48 hours. Next slide. Now we're going to go ahead and introduce our panelists.
Hi, everyone. I'm Henry Tran. I'm a third-year medical student at John Seeley School of Medicine. I just really want to thank y'all for being here to discuss this exciting topic, and I really think you'll find it interesting, and maybe, who knows, you could get inspired to enter the field of neuromodulation somewhere down the road.
Hi guys, my name is Sai Kama. I'm an MS3 here at John Seeley School of Medicine at UTMB. So I'm excited to talk about spinal cord stimulation today and hope you guys enjoy this.
I'm Caitlin Vilas. I'm also an MS3 at the John Seeley School of Medicine at UTMB. And like everyone else has said, I'm really excited to present this topic, and I hope that you really enjoy the presentation.
And I'm Alon Kunik. I'm also a third-year medical student here at the John Seeley School of Medicine, and we'll go ahead and get started. So to start off, we actually have a poll for everyone.
Sylvie, go ahead, next slide.
Well, before that, just wanted to outline what we'll be talking about today. First, we'll discuss what even is spinal cord stimulation, so the rest of the webinar makes sense. Then we'll discuss 2 landmark papers that were groundbreaking at the time and contributed greatly to the field of neuromodulation.
So we'll pause right here. So there is a poll. If you click on the poll at the bottom of your screen, there's we just want to gauge like how familiar you are with spinal cord stimulation. So we'll give you a few moments to pick one of the choices.
Okay, we'll give about 10 more seconds. All right, I think that's everyone.
Okay, so it looks like I'm sharing the results. I'm not sure if you guys can see it, but it looks like the majority of you are somewhat familiar with spinal cord stimulation, which is great. So then, it helps to have a little bit of background. And if it's okay if you don't know, we will kind of explain what it is to you and give you an opportunity to ask questions about it later. Next slide. Sylvie, next slide, please.
All right, so we'd like to start off by just giving y'all an introduction on the topic of chronic pain. More than 1.5 billion people in the world experience chronic pain, so this is a very prevalent issue in our population. Lower back pain is the most common type of chronic pain, affecting 23 to 26% of the population. And opioids are commonly prescribed to treat chronic pain, despite the lack of clinical evidence that shows that they're not very effective in treating chronic pain. They're more meant for acute pain and short-term management rather than long-term pain, because patients can develop tolerance, which makes the medications less effective. And there's also the possibility of addiction that comes with the opioids. Next slide, please.
So just a brief overview of spinal cord stimulation. First off, who is it even for? Spinal cord stimulation is used most often to treat pain that is neuropathic in origin, pain often described as shooting, burning, pins and needles. And classically, these are conditions such as failed back surgery syndrome, complex regional pain syndrome, and more recently, diabetic neuropathy. So what is spinal cord stimulation? So imagine a pacemaker, but for your spine. Basically, it's a medical device that involves a battery attached to a lead. And with the use of fluoroscopy, the lead is placed in the epidural space at the spinal cord level associated with your pain. So the battery delivers a low dose current that stimulates and essentially dampens or masks the pain signals from reaching the spinal cord and to your brain. This results in a mild paresthesia, a tingling sensation, instead of the burning, shooting pain that you would have had. I do want to emphasize that this isn't going to make you Superman. You're not going to be invincible. And the goal of spinal cord stimulation is to reduce pain, not block it completely. And as a result, potentially reduce the need for opioid medication and restore function. Next slide, please. So the nice thing about spinal cord stimulation is that you can try before you buy it. Like test driving a car, before you get a permanent implant, you first get a temporary device, which is trialed generally for 3 to 7 days, after which the patient can choose to remove it if it's not providing adequate analgesia. If the patient reports adequate pain reduction, then you still remove the temporary device, but then undergo a minimally invasive surgery for permanent implantation. Next slide, please.
So like Henry was explaining, spinal cord stimulation is a great treatment for chronic pain. It consists of using electrical stimulation pulses that are sent through spinal epidural leads at the vertebral levels that are associated with the pain. The frequencies that are used can range from 2 to above 10,000 hertz, although conventionally, it typically ranges from around 40 to 60 hertz. This is low frequency spinal cord stimulation, and the goal is to produce paresthesias, which are a tingling sensation that will overlap with the pain distribution and mask the pain. With this comes the need for intraoperative pain mapping. And with this, patients will give feedback and the doctors will minorly adjust the location, the frequency, the width, and the amplitude of the pulses to maximally mask the pain. Next slide, please.
So the first article we'll be looking at is a study done by Dr. Richard North. He was a brilliant Johns Hopkins neurosurgeon who contributed significantly to the field of neuromodulation throughout his career. One of the contributions was this landmark paper titled Spinal Cord Stimulation versus Repeated Lumbosacral Spine Surgery for Chronic Pain. It was conducted in 2005. And at that time, spinal cord stimulation had only just received FDA approval in 1989 for the treatment of chronic pain. And it was often viewed as very new compared to the standard treatment, which was repeat surgery. So I can't stress the importance of this paper and its findings in pushing spinal cord stimulation to the forefront of treating chronic pain. Next slide, please. So first off, who are the patients of interest in this study? So in the US, 10 to 40% of patients who previously underwent spinal surgery for pain had persistence or reoccurrence of that pain. Furthermore, they failed to obtain lasting pain relief despite receiving a variety of therapies such as oral meds or physical therapy, etc. These patients are experiencing what they termed at the time failed back surgery syndrome, and their pain is often complicated by depression, loss of employment, or loss of productivity. Treatment for these patients generally involved repeat surgery, and more recently at that time were spinal cord stimulation. The article highlighted previous retrospective studies that showed that FBSS patients who underwent spinal cord stimulation compared to those who underwent neurosurgical treatment resulted in not only lower morbidity, but also higher rate of success in terms of pain rating, neurological function, and the ability to engage in daily activities. Despite this, spinal cord stimulation at that time was generally reserved as a last resort for treating failed back surgery syndrome. Next slide, please. So this led Dr. North to perform a prospective rather than a retrospective randomized controlled trial comparing spinal cord stimulation to repeat surgery in patients who previously had back surgery and experienced persistent or recurrent pain. So the overall goal of this study is to explore the outcomes and merits of reoperation and spinal cord stimulation, and to determine would it be more appropriate to offer spinal cord stimulation as a late rather than a last resort. Next slide, please. So this slide outlines how candidates were selected for the study and how treatment groups were selected. So within the blue box, candidates were eligible if they had recurrent radicular pain after one or more spinal surgeries, and if the pain was potentially surgically remediable. Patients were excluded if their conditions warrant immediate reoperation, and this resulted in 99 FBSS candidates. Then the candidates were asked to consent to randomized treatment of either spinal cord stimulation or reoperation. So 39 refused, leaving 60 candidates randomized to either reoperation or spinal cord stimulation. Next slide, please. Looking at the green box, those who refused all chose reoperation. Those randomized to spinal cord treatment underwent the test drive I previously mentioned and can move to permanent implant if they experience greater than 50% relief and improved medication intake or physical activity. Those randomized to reoperation underwent a lumbosacral surgery as indicated by their individual condition, and those are just a list of possible surgeries they could have had. These three groups together were analyzed for their outcomes. Looking at the red box, patients from either randomized treatment arms were given the option to cross over to the other treatment. Next slide, please. So once the candidates were all selected, all patients underwent initial baseline evaluation consisting of psychological evaluation and functional capacity evaluation. Next, they would have a general health measures, which assess rating of pain intensity, medication intake, daily activity at the time of the initial evaluation. They were then followed for 6 months and then 2 years. At the 6-month follow-up, they had the same general health measures as in the initial, plus measuring of pain relief and patient satisfaction at that time. And the same occurred for the patients at the 2-year follow-up. Next slide, please. So previous slide. So I just wanted to define success as defined by this paper. They consider success as 50% or greater reduction in pain and patient satisfaction with treatment. Just wanted to bring note of this because it will be used later in the results. Next slide, please. Lastly, the primary outcomes measured in this study is the number of crossover to the alternative treatment, success at last follow-up, and improvement of daily activity, neural status, and medication use. And just keep these in mind when we discuss the results next, which my colleague Sai Kama will do now. Next slide, please. And thank you for listening.
Hi, guys. Thanks, Henry, for covering a lot of that introduction to methods. So now going on to the results of this study. So in the top right, you can see that there was 99 patients that started out in the study, and 39 of those actually refused randomization and chose to undergo reauthorization directly. And then that left us with 60 patients, which 10 of them had insurance issues, being that their insurance basically did not want them to get randomized. So that left us with 50 patients to be randomized across the two groups. So if you look at that flow chart on the right side, on the left side, you have the spinal cord stimulation randomized group. And then on the right side, you have the group that underwent reauthorization. So it's important to understand that all these people had one failed back surgery, and then that they were randomized after that. And then you can see that 5 people crossed over after having an SCS trial. 5 people crossed over to the reauthorization group, whereas 14 that had reoperation on the second time crossed over to the SCS trial. That's kind of in the center where it says crossover of that flow chart. And the groups didn't differ in sex, number of previous operations, or the percentage of axial low back pain. We can go ahead to the next slide. So then here, basically what the study found was that spinal cord stimulation was significantly more successful for patients than reauthorization. So Henry kind of covered that. That means that patients are reporting at least 50% pain relief to identify that they were satisfied with their treatment. So 9 of the 19 patients in the spinal cord stimulation group were satisfied versus only 3 out of the 26 patients in the reauthorization group. And then on the right side, in that table with the red highlighted box, you can see the operations failed and the specific subtypes, as well as how many were followed up long-term on the bottom right, because some patients were lost to follow-up. And then one thing to note is that 38 of the 39 patients earlier that I mentioned that were not randomized and automatically chose to undergo reauthorization, only 10 of those, so about 26%, had success, and 14 or 37% of that group wanted to undergo spinal cord stimulation because they've had 2 failed reauthorizations at that point. And of the 14 that underwent that after 2 failed authorizations, 6 of them ended up having success. So we can go ahead to the next slide. So some other results is that the randomized reauthorization group had significantly increased opioid use compared to spinal cord stimulation group. And that's one of the ways that we measure if the pain was truly reduced or not. And you can see that they're needing more pain medications. And then over here on the figure, we have group A, which is the reauthorization group at the top. They actually had more loss of function in many categories, as you can see. And the only 2 categories that they actually were, the reauthorization was better than the spinal cord stimulation group, was in the sex and sensory categories that I've highlighted in red boxes. And then, so we can go on to the discussion. So, really why this study is so important and why it's such a landmark article is because it was published in 2005, about 17 years ago. And it's basically disputing all the previous criteria that said that all reasonable alternative therapies for back pain, such as reauthorization and physical and behavioral therapy, should be attempted before SCS trial. Rather, this says that spinal cord stimulation is more effective than reoperating for persistent radicular pain after a failed lumbosacral spine surgery. So we believe, and as well as this article, that the minimally invasive nature, reversibility, and measurable improvements of spinal cord stimulation prove that reoperation should actually be deferred in favor of trying a cheap and minimally invasive spinal cord stimulation trial. And then the last slide I wanted to talk about, we can go to the next slide. Some limitations of this study were that 52% of the study population was retired or permanently disabled at the time of the study. So it's kind of hard for us to see if the spinal cord stimulation trial or reoperation would have helped people return to work. But no significant difference was measured in their ability, in their perceived ability. And then one thing that the study did really well was that they used a third-party interviewer for follow-up information to reduce interviewer bias. And that's to conclude our first article. And then we can go to the next slide for the next article.
All right, the next article is titled Novel 10 Kilohertz High Frequency Therapy, or HF10 therapy, is superior to traditional low frequency spinal cord stimulation for the treatment of chronic back and leg pain, the SENZA RCT randomized control trial. This paper was released in 2015 and is one of the key articles discussing high frequency therapy. All right, next slide, please. So to start off, just a little quick review on previous information that we've already talked about. The conventional or low frequency spinal cord stimulation, the goal of that is to produce a paresthesia that overlaps with the distribution of the patient's pain in order to mask the perception of pain and replace it with a paresthesia or a tingling sensation. In order to do this, the intraoperative paresthesia mapping is required, where the patient gives feedback in order for the provider to adjust the location, the pulse frequency, the pulse width, and the amplitude of the stimulation. And the range for this typically is 40 to 60 hertz. And the difference between the conventional low frequency therapy and the HF10 or high frequency therapy is that the high frequency therapy has a frequency of 10 kilohertz or 10,000 hertz. So it's a much higher frequency. This involves using a high frequency, low amplitude pulse in the spinal epidural space without producing any paresthesia. And since it doesn't produce any paresthesia, you don't need the paresthesia mapping in this procedure, which is one of the benefits. In this procedure, leads are typically placed to cover the T9 to 10 interspace, which is the sweet spot for the high frequency therapy, as compared to the conventional low frequency therapy, where the patient gives feedback to adjust the location of the stimulation. Next slide. So this study was a prospective randomized controlled trial. The goal of the study was to compare the high frequency therapy to the traditional low frequency therapy in patients who have chronic back and leg pain. The primary goal of the study was to assess non-inferiority of the HF10 therapy, meaning to show that it's at least as effective as the traditional low frequency therapy in treating chronic back pain and leg pain. The secondary goal was to assess superiority. So that would be assessing whether the HF10 therapy is actually more effective than the traditional low frequency therapy. For the population that this experiment involved, patients were chosen as consenting patients that were already under the care of the investigators. They were selected across 10 comprehensive pain centers in the United States, and the inclusion criteria consists of the patient having to have chronic trunk and or leg pain. They have to be refractory to conservative therapy, which involves pain medications, physical therapy, spinal injections, pharmacological and behavioral treatment. So they have to be refractory to these therapies and still have their chronic back pain or leg pain. The average pain intensity must be at least a 5 out of 10 on a pain scale, and they must have an Oswestry Disability Index score of 41 to 80 over 100. And this is just showing how much the pain impacts their daily life. They also must be a candidate for the surgical procedures that were involved in this study. The exclusion criteria that kept patients away from being eligible to be in this study included having a psychological or psychiatric disorder that might disrupt the study, having a known condition that would impact their perception of pain, if they're unable to comply with the intervention or evaluate their treatment outcomes, if they have a mechanical spine instability, or any prior experience with spinal cord stimulation. Next slide. The patients were randomized in a 1-to-1 ratio, meaning that an equal number of patients were in the control group, which was the low frequency conventional therapy, and it was equal to the amount of patients that were in the high frequency group, which is the experimental group. The randomization was stratified by gender and the primary location of their pain, meaning back or leg pain. And this study was not blinded, meaning that both the subjects and the investigators were aware of which group each patient was in. So in order to begin this study, there was a trial phase of spinal cord stimulation that lasted for up to 14 days in all of the participants. And in order to be eligible for this study, they had to have greater than or equal to 40% back pain reduction from the baseline. And if this is true, then they were eligible for the permanent implantation of the device. The traditional spinal cord stimulation group, the parameters were adjusted to optimally overlap the paresthesia with the region of pain, which is pain mapping that we already discussed. And for the high frequency group, 30 millisecond pulses at 10 kilohertz with an amplitude adjusted to their optimal pain response was used. Next slide. The procedure to actually place the implant in both groups, the same type of leads were used. They were 2 percutaneous leads that were placed in the posterior spinal epidural space, and they were attached to an internal stimulator for the trial period. And then when the permanent device was placed, then they are subcutaneously implanted IPG. The high frequency group had the distal tip of one lead at the midline of T8 and the other at the midline of T9, and the traditional low frequency group had leads placed at the vertebral levels that were based on the intraoperative paresthesia mapping that involved the patient feedback. So the location of these leads differed, while the HF10 group, it was all at the same location. Typically though, for the low frequency group, even though the location differed, most of the patients had it placed at the T7 to T8 level. Next slide. In order to assess the outcomes, they had to have some measurable outcomes. So they used the pain scale for back and leg pain, They used the disability index that we discussed earlier. They also used a global assessment of function and the satisfaction of the subjects involved in the study. For adverse event reporting, they used a standardized neurological exam involving motor, sensory, and reflex functions that were tested at 1, 3, 6, 9, and 12 months after the procedure. And then at the 3-month and 12-month visit, they were asked if they experienced any paresthesias, and if yes, was it uncomfortable to them, and was it related to their posture? Next slide. For the statistical analysis, they used intention to treat, per protocol, and permanent implant populations. If there wasn't a successful trial phase in the beginning of the study, then the patients were considered a non-responder for the intention to treat and the per protocol analysis. And so the patients were stratified into either responders who had the successful trial phase, meaning they had a greater than or equal to 40% reduction in their back pain, or they were classified as non-responders when they had an unsuccessful trial phase where their back pain wasn't reduced by at least 40%. Within the responder group, they were further stratified into remitters or non-remitters. Remitters had a pain score of 2.5 or less, and a non-remitter had a pain score of more than 2.5. The measurable outcomes in this study involved a greater than or equal to 50% reduction in their pain score without a stimulation-related neurological defect. Next slide.
All right, thank you for sharing, Caitlin. We're going to move on now to the results section. So just to give a general outline of what the study looked like, it had 241 participants to start off with. And after exclusion and various failed trials, there ended up being a total of 90 of the subjects who were implanted with the high frequency therapy and 81 subjects with the traditional spinal cord stimulation. And then the patients were monitored over a 12-month period. It's a longitudinal study. Next slide, please. So this is kind of one of the primary tables that the study provides. And again, to kind of rehash what Caitlin was talking about, the main goal and the primary outcome was to understand in terms of responders and remitters. A responder was defined as a 50% or greater back pain reduction with no stimulation-related neurologic deficits. And a remitter was a VAS pain score of less than 2.5. So if you focus yourself over to where the green highlighted box is, after 12 months, looking at responders and remitters for the chronic back and leg pain. So at 12 months for the permanently implanted subjects, 78.7% were back pain responders with the high frequency therapy compared to 51.3% with the traditional spinal cord stimulation. Similarly, 78.7% of the high frequency therapy subjects for leg pain were also categorized as responders compared to 51.3% with the traditional spinal cord stimulation. And now looking at the remitters, 68.5% were back pain remitters with the high frequency therapy, as well as in comparison to 36.3% with the traditional spinal cord stimulation. And then 67.4% of the high frequency therapy subjects were leg pain remitters compared to 42.5% for the traditional spinal cord stimulation. And we'll get into a little bit more detail as to what the significance of that is, but just generically looking, it shows you that there is some reduction that is significant in terms of both response and remission for both chronic leg and back pain. Next slide, please. So this is another visual from the study itself, kind of giving an indication of the VAS pain score. And so if you look all the way on the top of the axis here, that's where the VAS pain scale starts, that the numbers that are around 7 to 8. And then this maps it over 3, 6, 9, and 12 months. So for the back pain with the high frequency therapy, the mean back pain VAS decreased from 7.4 to approximately 2.5, which is a 67% reduction over the 12-month period. And that's in comparison with a decrease from 7.8 to about 4.3, which is a 44% decrease with the traditional spinal cord stimulation. If you're looking at the leg pain, the high frequency therapy had a VAS score of a 7.1 at baseline, and the reduction after 12 months was to a 2.1, and that's a 70% decrease in comparison to a baseline of 7.6 on the VAS scale that dropped to 3.8 after 12 months with the traditional spinal cord stimulation. So I just think this image here provides a good visual of the fact that with both spinal cord stimulation, the traditional method and the high frequency method, you see a reduction in that VAS pain scale. But with the high frequency, you're seeing an even higher significant reduction compared to the two. Next slide, please. So just to kind of summarize what these results showed, the HF10, the high frequency therapy, provided superior pain reduction than spinal cord stimulation for both chronic leg and back pain over a 12-month period. And that's really significant because we hadn't looked chronically and longitudinally what that high frequency therapy really would do. And then the secondary findings for this study showed that it actually had a decrease in opioid analgesic use across all patients. The treatment reduced the level of disability across all patients. These were subjective findings. There's a disability scale that was used in the treatment and in the study themselves, and these were reported findings. And the subjects with the high frequency therapy did not experience the paresthesias compared to the 46.5% of the subjects that experienced them with the traditional spinal cord stimulation. And these paresthesias are reported as very uncomfortable sensations for the patients. It is used in order to map the pain and in order to kind of mask it and distract from that pain. But if we have an opportunity to have treatment that does not produce these paresthesias and these uncomfortable feelings, then that can looked at as a better treatment. And so the fact that we see with high frequency therapy, this reduction in pain and remission in pain without the unwanted paresthesias, that's a very significant understanding and thing that this study showed. In terms of adverse events, no stimulation-related neurologic deficits were found in this study. There was one death in the study, and this was due to a myocardial infarction. This wasn't attributed to any kind of stimulation-related event. And the only common adverse event with relation to the study on both the high frequency and spinal cord traditional stimulation was that there was implant site pain in about 11% of the patients. Next slide, please. So overall for the discussion, again, the overarching goal is we're trying to find effective management for chronic leg and back pain. These are highly prevalent issues within our society. And there's pharmacological interventions such as opioids that are ineffective for chronic pain and really should only be utilized for acute pain and in specific settings. And the research is targeting understandings of what are our other options. And so what did this study really do? It was the first scientifically rigorous randomized controlled trial that demonstrated the superiority of the high frequency spinal cord stimulation over the traditional spinal cord stimulation in a long-term treatment of both chronic back and leg pain. It showed a significant reduction in subsequent remission of the pain over a 12-month period in comparison to that traditional spinal cord stimulation. So for us, this means that the high frequency therapy could potentially have significant impact on the management of chronic back and leg pain. And it really just is a field that is continuing to expand now. And that's something I'll kind of get into in our wrap up. Next slide, please. So just to talk about some of the limitations that the authors noted, there was an interaction of spinal cord stimulation with pain medications. Changes the opioid analgesia had potential confounding of the effects of the spinal cord stimulation. Patients weren't allowed to go up in their opioid use, but it was noted that typically there wasn't going to be overt changes to the opioid use. And so if patients had opioids on board, that could potentially confound some of the data that we see. But again, like I had talked earlier, some of the secondary findings were the fact that across the board, a lot of patients were reducing their need for pharmacological interventions, such as those opioids that they had prior to. But it wasn't something that they specifically studied, so it is something they had to note as a potential confounding variable. And then earlier, we kind of talked on this, that the investigators didn't have an opportunity to mask the treatment groups, especially because spinal cord stimulation, you have to do that intraoperative pain mapping. And so explaining the procedure and having full consent, the patients are going to understand which one of the procedures they're undergoing. So there really isn't an opportunity to have blinding. And that's just, they said that this is kind of their best opportunity for creating this trial, and they understand that that is a limitation. And then lastly, pain is a subjective measure by nature. It is very difficult to measure, and it is very difficult to create a scale for that. The article notes that they said they feel as if they use the best pain scale. The VAS pain scale is a widely known pain scale that is utilized in a lot of different studies, but understanding that this is something that is highly subjective and hard to measure in varying subjects with so many different confounding opportunities. Next slide, please. So just some final thoughts now that we've talked about two of these landmark articles in pain management and chronic pain management. Again, chronic pain really is a highly prevalent issue with not very many effective strategies to manage it. We've talked about pharmacological interventions, we see there's surgical interventions, and now we're starting to see that there's minimally invasive spinal cord stimulation options. And really what we wanted to do was highlight that in this first article was the landmark idea that in 2005, there was strong evidence showing that spinal cord stimulation is actually an effective option for chronic pain. And the first article really showed that evidence that it is significantly better than traditional options such as those surgical interventions that we saw. And so starting at about 2005, we started to kind of see this field growing and understanding that this is an option and this is something we need to continue to look at. Fast forward to our second article, looking at the traditional spinal cord stimulation in comparison to the high frequency stimulation. We knew that the traditional stimulation was going to have pain reduction and remission because the previous studies have had sound evidence for that. What the goal of this study in 2015 was really, okay, now that we have this technology, we're trying to refine it and understand what are our better options within it. And this was one of the revolutionary and really groundbreaking studies that showed high frequency spinal cord stimulation yields reduction and remission of chronic pain without those unwanted paresthesias, which is a really significant opportunity for patients to have even further reduction in their pain and remission in their pain without the need potentially for other pain management options and medications and some of these unwanted side effects that have come with the traditional therapies. So overall, we felt it was just really important for us to kind of highlight where we are and how we've gotten here in terms of what does spinal cord stimulation look like? How does it help treat us? And really, where are we going with it? And how is it going to continue to move forward with that research? And so that's kind of the end of our presentation. We now have some questions for our moderators. So the first question we had was, what are some of the other indications for spinal cord stimulation? What is it used for?
Yeah, excellent question and fantastic job with presenting both articles. Like I said, these are two landmark articles that have really kind of pushed the boundaries in spinal cord stimulation and neuromodulation. So it's really good to kind of be able to dig a little bit deeper and go through these articles in detail. So to answer the question, so there are a few indications. Failed back surgery syndrome is one of the most common indication for spinal cord stimulation. And it's the indication that was used in the first article. Other common indications that we typically come across are complex regional pain syndrome and peripheral neuropathy, such as painful diabetic neuropathy. In Europe, they actually use spinal cord stimulation for refractory angina pectoris and then peripheral painful limb vascular disease are some other common indications that can be used.
Great. And next question, can you kind of discuss the spinal cord stimulation trial in a little more detail on what all it entails? Also, what are the factors that you look for when assessing if spinal cord stimulation trial is successful?
Excellent question. So I think I love the analogy that was given earlier in the talk about using spinal cord stimulation trial is very similar to like test driving a car. And that's how I kind of typically describe it to a lot of patients. So it's basically you get to try out the entire device percutaneously before you commit to it. So a trial typically lasts on average about 3 to 7 days. We typically insert the leads very similar to how you do an epidural steroid injection, and you're kind of basically threading the leads into the epidural space. Once the leads are there, they're actually attached to an external IPG. So the small battery device that would actually be implanted within the skin is actually outside for the duration of the trial itself. So during this test drive, the device representative, the physician, and the patient will work very closely together. They're going to adjust parameters to kind of find the optimal analgesia. And typically during this time, we usually ask like the patients, please like take note of what your pain score is, what your functional level is, how much you're able to walk, move, and do kind of the things that typically cause your pain. And keep note of that. At the end of the trial, the patients come back to the office and the leads are removed and the test drive is over. So during that time, the patients are able to kind of feel what their symptoms are without the spinal cord stimulator leads within their body, and then how it was when it was during the trial. So it kind of gives them the opportunity to assess their pain without the leads and whether they want to pursue the implantation. So I think it's a really nice feature in the sense that you can really kind of test it before a patient commits to it. And now, sorry, to answer your second part of the question, factors you want to look for. So the articles really do talk about pain reduction. And that is one of the factors that is typically looked into. So like typically a pain reduction score of about 50 or greater than 50%. But in addition to that, you want to really look at improvements in function, right? Are they able to walk longer, able to stand? Are they able to go back to work? Do things that they typically weren't able to do prior to the spinal cord stimulator. So those are kind of things that you want to look to, and you really want to kind of have a really detailed discussion with your patients when you're really assessing this therapy for them.
Awesome. Thank you for answering that one. Really helpful. Last question for you. How has the innovation of spinal cord stimulation and high frequency therapy impacted the landscape of pain medicine overall?
So great question. So these therapies really open the field for more novel waveforms for spinal cord stimulation. And in general, just kind of points to how like this field started developing more minimally invasive interventions and giving patients more options other than just back surgery. And this kind of points to how pain is a greatly evolving field with a lot of potential for innovation. So if you're interested in pain medicine as a career, pain medicine is a 1-year fellowship, which you can enter through multiple different specialties, anesthesia and PMR being the biggest ones. The other ones include neurology, psychiatry, and even emergency medicine. So we're also going to field some questions from the audience. Looks like we have 2. I'm going to start with the first one from Mark. So his question was there a replication randomized control trial? How did this or these studies influence current practice guidelines on treatment recommendations for treatment-resistant back pain?
So I think that, this is a very excellent question. I think one of the things to really kind of know is that when you kind of look at where these articles kind of were published, the first one was in 2005 and the other one was in 2015, it really does kind of shape the landmark in terms of where spinal cord stimulation and neuromodulation itself as a field was really developing and kind of where we're going with it. So I think that overall, like the treatment guidelines are constantly changing. And there's more indications and more waveforms and different types of stimulation patterns, frequencies, and parameters are coming about, which will continue to shape overall recommendations for treatment of back pain and other types of neuropathic pain.
Okay, and then we have one more question. So Jameson asks, another question regarding the second article. How much do we take into account the lack of blinding with the high frequency and standard spinal cord stimulation interventions? Is it even a major concern, or do we have to factor in a placebo effect as the patients may see the newer intervention as better?
Yeah, I think that's a really good question. I think the one thing that the authors kind of really did mention is that this was kind of really the best that they could really do given this situation, right? You have one treatment that is paresthesia free and you have the other one that has paresthesia. So it's really kind of really hard to blind. In terms of how can we really take this into effect and major concerns, it's a little bit kind of difficult to kind of really pinpoint and kind of see if that's a major concern. But I think the data overall, the study was very well done in terms of like how they can kind of confound for those variables. So I think that is something that we can play into for future studies and kind of going forward.
Okay, one more question from Jameson. Since the high frequency intervention was more effective, could we theoretically increase the frequency even more to assess that benefit?
I think that's excellent. I think that there will be studies coming in the future. Unfortunately, I'm not aware of any studies currently looking at frequencies higher than the high frequency 10,000 kilohertz that was mentioned in this article. But I think that as kind of we get more information and more research for other indications and kind of waveforms, I think we'll be able to see what is the frequency, like which frequency is going to be most optimal for patients in different populations.
Okay, and a question from Millie. Can this be applied to cluster headaches?
Excellent question. To my knowledge, I'm not aware of spinal cord stimulation being used specifically for cluster headaches. That is something that we can look into a little bit further regarding research studies. From my experience, I have not seen that.
Okay, another question from Edward. Would you happen to know the general landscape of STEM utilization, private practice versus academic centers?
Another excellent question. So I think that spinal cord stimulation has been used in kind of both settings, seen it in private practice as well as academic centers. So I think it's pretty widely used. But one of the things you really want to kind of be mindful is that picking the right therapy for your patient. So spinal cord stimulation may not be the right therapy for every patient. And it's really important to kind of think about the etiology of their pain, what conservative methods have they tried, and really have those detailed discussions with your patients before you discuss spinal cord stimulation and kind of have them involved in that discussion. So, but the general landscape, it is being utilized in both private practice and academic settings.
Okay, so those are all the questions. We'll give you guys, the audience, like maybe like a few more seconds if you want to answer any last minute questions. In the meantime, I'll talk a little bit about joining NANS. So here's a link in the slide. I'll also drop a link in the chat so you guys can go to the website yourself. Let's see here. So joining NANS, what do you get from it? Well, you'll get email updates on NANS events, access to members only portion of the NANS websites, which have a lot of educational videos and materials. You also get discounts to annual meeting and educational courses, as well as priority for enrollment. And you also get a subscription to the Neuromodulation journal and the newsletter. And if any of you are interested in presenting at the next Medical Student Journal Club, feel free to email the email address below, which is info.nansrfs@gmail.com.
I don't see any other questions, but just to kind of go back to that cluster headache question, I did do just a quick list search. So there are some studies showing its use for cluster headaches. But I think that may be a good topic to discuss in the future and kind of dig a little bit deeper through some of those studies to kind of see the indication. But as neuromodulation as a field is evolving, there are many indications that are kind of to be developed. So it'd be really interesting to kind of see this field kind of grow and develop over the next decades. And Sylvie, can we go to the next slide, please? And I do want to, we do want to invite you all to the NANS annual meeting. It's going to be taking place this January, January 12th to 15th in Las Vegas. This is a great meeting for all. I remember I went as a medical student. I found it to be an amazing experience. You get to connect with colleagues. You get to meet a lot of some of the leaders who are writing these studies and kind of conducting the research. And you got to really get to hear about great experiences regarding neuromodulation and kind of what's coming up in the forefront. So I really highly recommend it. I think it's a great conference to kind of come to. And there is a resident fellows section, and will be a young neuromodulators reception, which all the medical students are more than welcome to attend. So we hope to see you there. All right, everyone. I think that kind of concludes today's Journal Club. Again, thank you to all of our panelists and presenters for taking the time to kind of go over these articles. And thank you for all the attendees to joining in today. And thank you for all the questions. Again, if you're interested in presenting an article or just kind of being a little more or getting involved in NANS, feel free to reach out to us. Our email address. Sylvie, can you go back to the last slide, please? Our email address is right there. So feel free to contact us if you have any questions regarding the field, regarding neuromodulation or NANS in general. We'd be more than happy to connect you with someone. Thank you again.